Good evening, everyone. Here Imran Abbas from Dubai. Again, we are live with another legend of surgery, Professor Jammu from India. He is also expert of MGB, OAGB, and he is also one of the pioneer of OAGB in India. It is great honor to interview such a prestigious figure. Sir, over to you, sir. Really thanks for your time and your support. Sir, this is the time. Please, sir.
Thank you, Dr. Imran, for inviting me on this series of webinar. I'm really obliged. So, and to all the viewers, my greeting from India, from the state of Punjab. So, not taking much of time, we'll come straight to the subject. Yes, Dr. Abbas, what do you want me to speak on?
Sir, thank you, sir. So as you know, and we discussed earlier, so this is the series of MGB, OAGB. We have started with Professor Robert Rutledge, and we will continue this series. Now, as you know, from all over the world, so we had expert of MGB, and also it was great experience, especially for me, and they share their personal experience. And behind these interviews, the main theme is this. So, share personal experience of MGB, especially during this COVID era. So, we have used this online and this way of sharing the knowledge that was very effective, and also a great response from all over the world. Now we have thousands of viewers. Just now, we are also live on Facebook on global laparoscopy. So, sir, then we will continue this series, and in mid of this June, we will have sum up session. After this series, we will continue series of sleeve gastrectomy for 6 months, then a series of Roux-en-Y gastric bypass, then series of these metabolic surgeries in low BMI patients. At the end, in 2023, we will continue series of redo surgery. So now today we will continue our series of MGB, OAGB. As you know, we have some repeated question. So we will continue our interview according to these questions. First of all, sir, so your brief introduction, please, sir.
Okay, thank you again, Dr. Abbas. So to introduce myself, I come from India, the state of Punjab. And I am into bariatric surgery since the year 2007, when we first performed Roux-en-Y gastric bypass in our state. That was the first time in the year 2007. Then we performed series of Roux-en-Y surgeries, and followed by sleeve gastrectomies. They are good surgeries, but they had some inherent problems, like limitations, or you can say shortcomings. That prompted me to switch over to mini gastric bypass when I met Dr. Robert Rutledge in the year 2009 in India itself. I learned mini gastric bypass. I saw him doing mini gastric bypass, and then I started doing it myself. And that was a time when I compared my results of Roux-en-Y gastric bypass and the laparoscopic sleeve gastrectomy with the new procedure, that is mini gastric bypass. And what we found, not only the results were far better, but the complications were also less. The complication rate was far less. So I got inclined towards mini gastric bypass because with mini gastric bypass, although the one is, it's a simple procedure. Second thing is there's more weight loss, more of excess weight loss as compared to Roux-en-Y gastric bypass, we all know, as compared to sleeve gastrectomy. The resolution of comorbidities like type 2 diabetes, hypertension, dyslipidemia, and other things were far, far superior as compared to their other counterpart procedures, Roux-en-Y and sleeve gastrectomy. The morbidity, the mortality was far less than the other procedures. So that made me inclined towards doing mini gastric bypass. And Jammu Hospital, which is we have in the city of Jalandhar, this is a high volume center and a center of excellence accredited by a Surgical Review Corporation, US, as well as NABH, which is India's highest accrediting body in the healthcare industry. So we have been accredited as a center of excellence by both these organizations. And we do mainly MGB or OAGB. And sometimes in some, when these are contraindicated, we do the other procedures. The beauty of mini gastric bypass is that it has so many exit routes as well. So supposing there is some complication, mini gastric bypass can be easily converted to other procedures, even the sleeve, it can be converted to sleeve, it can be easily converted to Roux-en-Y gastric bypass. And the best thing, it can be undone. We can always undo the mini gastric bypass, which is the hallmark of this procedure. Say the procedure patient is landing into some severe protein or severe iron deficiency or some other problems, we can easily undo these procedures as compared to the other procedures. So that prompted me to become a fan of mini gastric bypass. And we are, before this COVID era, my center was, we were doing about 40 to 50 surgeries per month. That comes to about more than 300 to 400 surgeries per year in this city of Jalandhar. So I have even published a study. During the further discussion, I'll show you what study we published in the year 2015, the obesity surgery, which is the most cited Indian study so far in the series of mini gastric bypass publications so far.
Sir, excellent. So, as you have mentioned, you have started MGB since 2009, and also just you have touched so the journey of this MGB. So, my questions are, so because you know better than me, so every surgeon when start any type of process, so when practically he sees some things or results and also compare his results. So have you changed your technique during this more than one decade you are doing MGB for better results? So can you explain, sir, which points or which, especially that area you have changed?
Yes, very important and very nice questions, Dr. Imran. Yes, I have changed few technical modifications we have made in my technique of mini gastric bypass. Like I told you in the 2009, when we started doing mini gastric bypass, the problem which we encountered in the beginning was that sometimes we faced problems with severe nutritional deficiencies, particularly low albumin levels, low protein levels when bypass length was more than 200 centimeters, even at 200 centimeters. And that was the main problem. And I think we learned from our own series, then we learned from my own colleagues, even you and some other publications. We read those papers in the conferences, we exchanged the ideas. So in the beginning, Dr. Imran, I had in my publication, which I published in 2015, where we compared results of mini gastric bypass, results of sleeve and Roux-en-Y gastric bypass of about 1100 cases over a period of 7 years. What we found that the results were good, but in about 18 to 20 cases out of 400 cases of mini gastric bypass, we found there were severe albumin deficiencies. Albumin levels did not improve in spite of uh, all the best protein supplements we could give it to the patients. So they were below 2 grams. So in about 18 patients with severe all dietary modifications, we were able to achieve the results. But in 2 or 3 cases, we had to undo the surgery. And in one case, we had to shorten the limb of bypass. But that was a learning experience because in the beginning, we did not have any publication about the biliopancreatic limb lengths. So we were all new to all these things. And then we made some formulations, which I'll be discussing, that we reduced the length of bypass according to the BMI of the patient, according to the age of the patient, according to the eating habits of the patients. And then we were able to reduce that complication of low protein deficiency and low albumin deficiency. Now we have made a formula where we calculate how much bypass has to be done. It is almost a tailor-made. It's never a fixed bypass length. Uh, it is based on the age, eating habits of the patient, and BMI of the patient, and other comorbidities like even the thyroid, if the patient is low on thyroid, and if patient is having very much uncontrolled type 2 diabetes or dyslipidemia and sleep apnea sort of things. So it is based on those factors, which we'll be discussing the subsequent questions as well.
Sir,
So,
excellent. Yeah, please.
so I have tailored the length of bypass, and that was the main technical thing which I learned from my past experience. And another thing we have made is, of course, gastric tube is always made very long. It is not very wide. It's always narrow. And we see that the length of the gastric tube is nothing less than 18 centimeters, starting from the proximal part of pylori. It should not be less than 18 centimeters, because when you make a longer tube, you reduce the chances of this bile reflux or the alkaline reflux. This is what we are second. In the shorter tubes, always the chances of GERD are more as compared to longer tubes. So these are two modifications which I made over the period of my practice.
Sir, excellent. So definite, we will discuss in detail about tailored BP limb, because you know better than me. This is one of the important point in my opinion. Sir, as you know, because when so I was junior as compared to you starting MGB. I have started MGB in 2013. I remember at that time, so it was my main concern was marginal ulcer and bile reflux. So also at that time, maybe my pouch was short and some issues. Yes, progressively, I have personally I have changed, and also recently, Di Maria also mentioned these issues for the patients, earlier patient of Robert Rutledge in US. So, sir, now when we are sitting in 2021. So after all of these technical changes and also this PPI and everything and control of H. pylori, still this is the main concern.
Dr. Imran, I don't think so. Marginal ulcer is a big problem in this part of the world, in the state of Punjab, because apart from other reasons, one of the reasons in marginal ulcers is smoking, which is very less in the state of Punjab. So people smoke very less. That is, I think, the reason. In my also series, we don't see more than 1 or 1.5% of incidence of marginal ulcers in my practice. And out of all this, about uh, 4,000 cases, what we have done so far in my practice, never we have seen a perforated marginal ulcers. Yes, I do routine endoscopies on my patients. We have marginal ulcers, but we were able to manage most of them with these PPIs and other dietary modifications. In one patient, we had to revise the gastrojejunostomy because that ulcer was non-healing. We had to completely revise. But the incidence is not more than 1.5% in my series. Apart from other factors like smoking is very less in this part of the world. So that is, I think, one of the reasons.
Sir, excellent, sir. So because this is very important for all of us to hear from person who did more than 4,000 cases. That is amazing in one decade. Sir, another question regarding GERD. So this is also another issue. GERD before surgery. So GERD is also, you know better than me, is a wide. So definition is so we can this is the definition of GERD. So we can ask from a simple reflux to symptomatic to documented. What is my question? If a patient before surgery with symptomatic GERD or symptomatic reflux, and also you detected documented GERD, yes, your endoscopist also confirm patient is suffering with reflux, or you go for MGP in such a case?
Yes, I will still go. In endoscopy, if you find the patient is having a reflux and if you see their hiatus is very lax, then my approach will be still go for MGB and do some posterior repair of the crura and fix that thing, and you can safely do mini gastric bypass. I have encountered a few patients where we had very wide hiatus and we did the posterior crural repair, which is a very shorter procedure. You know that doesn't take more than 30 minutes to do that. So after doing that, and when we do create a mini gastric bypass pouch, you know that you have created a stomach which is now low pressure.
Yeah.
So itself mini gastric bypass, you reduce the pressure. Second thing is when you make a T connection of the end of the stomach with the jejunum, you are making a T. So that will give a downward traction on the stomach. So it will pull the stomach further down. So when you find there is hiatus hernia, you repair it, and just putting 3 or 4 sutures will save your patient from the further reflux. In a previously documented patients, and if you find that there's a larger hiatus, you can always fix that, and if you can save your patient from further deteriorating reflux, or rather reflux is almost gone after the surgery when you do all these precautions. And sometimes there is de novo reflux also. I've seen when patients, you do not, on endoscopies, you don't find any GERD. But after the procedure, I've seen that there's sometimes it can occur, maybe due to some marginal ulcers. Then there are other exit strategies. Uh, if you say, I can discuss what are the exit strategies if you find de novo GERD after the surgery. One is you can always do bronze anastomosis, that is side to side jejunostomy can help you sometimes. But better than that would be you can always divert the biliopancreatic. You can do a diverted MGB like Rui Rubiro's method. You can always divert the biliopancreatic limbs. We make a sort of Y connection or Ru and Y connection without reducing the size of the stomach. You
I
try to
understand.
understand in one Y gastric bypass where you make a very short stomach, but in diverted MGB the stomach length is same. You can divert the biliopancreatic limb and you can save the patient from further reflux. So there are exit strategies.
Sir, excellent. So from this debate, have you any experience of this like Ru and Y, or no? You personally you did?
I did not do Ru and Y. I have diverted like a Rui's method, diverted MGB. I had one because of some intractable reflux I have done. And I also attempted one bronze. But to tell you very frankly, diverted or doing Ru and Y construction is better than doing bronze. Sometimes bronze will take a longer time to settle down as compared to the Ru and Y reconstructions. So my personal experience is that if you have to choose one between bronze and Ru and Y reconstructions or diverted mini gastric bypass, I would say choose Ru and Y or the diverted mini gastric bypass and keep bronze. uh, I think you should not do that because uh, patient will not give you third chance to repair that thing. So we have to do all these things in one go because patient is already suffering. So that is my bias on that. If you have to choose one best thing to prevent this or to rectify this problem.
Sir, one of the concern in this Roux-en-Y gastric bypass is marginal ulcer, and when we compare marginal ulcer between Roux-en-Y and MGB, so overall symptomatic marginal ulcer, I am not talking about silent marginal ulcer that you can detect with endoscopy. Symptomatic marginal ulcer in MGB is lesser than Roux-en-Y. Why? Till the pouch is bigger, more acid, but due to bile and buffering effect of bile, so maybe we can face less. So this number of symptomatic marginal ulcer. So what is my question? If you will do Braun, if you do change to Roux-en-Y gastric bypass, then this buffering effect will go. Then there will be more chance of marginal ulcer because our stomach, this pouch is bigger than that Roux-en-Y pouch and more acid, and then there will be more chance. So because you did only one or two cases, maybe it is very difficult to judgment of this.
Yes, Dr. Imran, you are right in your part. But what I was trying to tell you that if you want to manage the reflux part, I mean the bile going into the stomach, if that is troubling you, then you can do a diverted thing because if you want to prevent bile from going there. I never said this is a treatment for this marginal ulcers. So this is for preventing bile going into the stomach and subsequently the esophagus. If you see an endoscopies and patient is complaining of this bile vomiting or bile going into the esophagus or stomach or the heartburn repeatedly, and you see in the endoscopies as patients say on the lying down, bile is coming, some yellow fluid is coming out of his esophagus or the mouth, or he frequently spits out this bile, then this is a treatment that if you want to stop bile from entering your stomach, then you can divert your bile. Otherwise, for marginal ulcers, it is not recommended that you do diverted MGB because ulcers are mainly present on the jejunal side. They're hardly present on the stomach side. You all know that. So acid is not the problem. The problem, I think, is the base, because as you say, it is a buffering action of acid and the base. Had it been acid, the ulcers we would have seen on the stomach side, but we always see ulcers on the jejunal side and hardly on the stomach side.
So no, sir. What is my question regarding this? I know this is not treatment for marginal ulcer, but after this change, so maybe the chance of marginal ulcer will
Yes,
be increased. So then we can
that will.
see to Roux and Y. So then we can.
Yes. We are not, yes, we can stick to only one procedure. I say that is the easily exit route that you convert to diverted. Yes, Roux Y, of course, still stands there. If you want to go a bigger invasive thing, you can always do the Roux Y reconnection. Yes, I accept that thing. Yes.
Thank you, sir. Sir, another question regarding this GERD. If you have a patient GERD after a sleeve gastrectomy, so you did a sleeve gastrectomy, no patient is suffering with GERD, and also there is a migration of this sleeve part inside mediastinum. So in such a case, have you any experience to change mini gastric bypass?
From sleeve to mini gastric bypass or sleeve to Roux Y gastric bypass,
Sleeve
yes,
to,
you can.
sir, sleeve to mini gastric bypass, sleeve with GERD, with migration, not weight regain.
I have never done that procedure, but it can always be attempted. I have never not done in my practice, because I've reduced the doing sleeves in my practice nowadays. I hardly do sleeves unless the patient is very young, or you cannot do bypass procedures, or there's some other indication. Theoretically saying, I think one should be able to convert sleeve to MGB after that. We have converted only those sleeves to MGB where there was a regain of weight or inadequate weight loss, but never due to this problem.
Sir, what is your protocol of pre-op endoscopy? Or you do routinely for all of your patients or select?
Yes, lately we are doing in all our patients. I do it myself before surgery. We do it, and we also do HB testing also, because I have encountered few patients after the surgery. We found that patient was H. pylori positive. So now, as a matter of practice, this is only 1 minute test. I take the biopsies myself and do it itself on before the surgery. And if you find the patient is positive, we have made a protocol that we have to eradicate H. pylori before the surgery, because you all know, because we cannot do endoscopies in the bypass stomach. It's not easy to do in the bypass stomach. So that is one protocol we have followed, and the incidence of one blame which comes on mini gastric bypass is that there's a CS stomach, you cannot diagnose, you cannot do endoscopies. So just to overcome that complication, we have started doing endoscopics and all of procedures. Post-operatively, endoscopies are not done unless patient becomes asymptomatic. Only in the symptomatic patients we do post-op endoscopies, or there's some study to go on. Otherwise, we do not do post-op endoscopies unless there is some problem with the patient.
Sir, excellent. Sir, now you have your center is one of the busiest center in India and also in, I think, in the world. So as your number, so 30, 35 or more than 30 cases per month. So this is in my opinion, excellent number. And also, so sir, when you are do routinely endoscopy, have you changed your plan due to endoscopy? And how many cases you think 5%, 10%? Yes, you have planned MGB, okay, for your case. So when you did this endoscopy, oh, so this is something wrong and it's better to do this one.
Yes, that is the reason we have started doing endoscopy in all of my patients. I cannot tell you the exact percentage, but I have changed the procedure or postponed the procedures other because of endoscopy. About 7-8 cases where we found on endoscopies H. pylori to be positive. In those cases, we have done. Otherwise, I have not seen on endoscopically why we had to change the procedure except for H. pylori. Yes, we have changed from procedure from mini gastric bypass to sleeve when we have found the liver to be very having some excessive fibrosis or sort of a cirrhotic thing. Then we have changed the procedure. On endoscopic, the only indication is when you find the patient is H. pylori positive, then you postpone the patient until the patient becomes negative.
Thank you, sir. Sir, regarding post-op surveillance of endoscopy, have you any protocol for MGB?
Like I told you, we do not do routine post-op endoscopies in patients unless patient was H. pylori positive in the beginning. In those patients, only we do after 3 months of surgery, we do the repeat endoscopy. If still we find that patient is H. pylori positive, then again the course to eradicate that is given, and subsequent endoscopy after 3 months is again repeated until the patient becomes negative for H. pylori. Otherwise, endoscopy is not done only in symptomatic patients where patient complains of reflux or some heartburns or some dysphagia, only on those cases. Routine patients who are asymptomatic or who do not show a history of H. pylori, we do not do endoscopies.
Sir, regarding this especially you have mentioned here this protocol of endoscopy after surgery. So what is your protocol of PPI? So in these cases, so this is routine until which?
The PPI we do give in all our patients of mini gastric or any bariatric procedure, we give PPIs to all our patients at least for the first 3 months. Then we stop it, and then we do give the patient as per the need of the patient. When patient complains or something, they have some complaints. Otherwise, we stop the PPIs after 3 months usually.
Sir, regarding hiatal hernia, if you detect hiatal hernia before surgery or during surgery, so have you any standard to for chororoplasty, any size of hiatal hernia?
This on endoscopy, it's difficult to decide. Only you can see the legs hiatus. Intraoperatively, when we see that when we make a tube of the stomach and we see that it is very lax, it's more than say 2 fingers wide leg. You can see that the distance between the crura is there. Then we always repair that, and 2 or 3 stitches are usually sufficient. And I normally do posterior repair, which is a very easy job to do. It doesn't take more than 30 minutes to do that procedure.
Sir, have you any experience? You see, yes, there is a relax hiatal and hiatal because in morbid obese patient, this is because now our viewers, most of our viewers are youngsters and they want to know about this. So just have you any experience? You see, yes, there is a relax hiatus and also more than 2 fingers, and you did MGB without chororoplasty and condition become worse.
Yes, Dr. Imran, it was in one of the difficult cases, and because we have patient was really short-statured, high BMI, so the things were really inaccessible on that patient, and with severe sleep apnea, anesthetist said that do not prolong the surgery. So in that cases, we took the chance of not doing a posterior crural repair of hiatus hernia in spite of the hiatus hernia. Patient preoperatively did not give us very positive history of some GERD thing. In that particular patient, we had this problem. Patient frequently complained to us about this reflux problem because of the hiatus hernia, and that was really troublesome patient for us. So, but we waited for another 3 months. Then patient lost some weight. Then we again went and did the posterior repair in that particular patient. Yes, that was one patient. So now, as a matter of fact, when we find that patient is symptomatic, we always buy some time, or we plan accordingly that we have to repair the patient. Otherwise, if you leave such a patient, the patient can give you trouble sometimes. So you have to be mentally prepared, prepare patient and their family also, that surgery can be prolonged and we have to repair. Otherwise, you have to undergo the surgery again sometimes.
Sir, regarding tailored BP limb, so that is the most important. So what is your standard? What is your formula for generally? And then
Dr. Abbas, if you give me, I want to share one slide with you, and that thing
please,
that will be self-explanatory. Give me
please.
1 second. I want to bring that slide. Is my slide visible?
Not yet, sir. You can share from my side. You can share.
Okay, okay.
Just you, first of all, you can go desktop. You can open from desktop and then you can click share screen. Sir, you can click share screen.
I'm trying. Give me 1 second.
Yeah. When you click share a screen, then you can share your slides from desktop. There will be no issue.
Now
Yes.
it is visible?
Yeah, visible.
Okay. So, sir, this is the slide. This is the formula of what we do in all my patients now, and this is the retrospective, uh, I think, formulation what we have calculated when I published my study. So, what we found that patients with a longer bypass length, they had some nutritional deficiencies. So we uh, studied our data again, and we found that patients in which these were the BP limb lengths, the patients did not have much of the nutritional concerns. So we made a formulation that below pediatric limb length should be equal to standard bypass length plus the BMI. So what is standard bypass length? Till the age of 45 years, the standard bypass length in all the patients is 160 centimeters. So that means a patient who is about 40 years of age has a BMI of 40, the bypass length, the BP limb length will be 160 centimeters plus 40, that is 200 centimeters. In another decade, patient 46 to 55 years, we reduce the standard bypass length by 10 centimeters. That means a patient who is about 50 years of age having BMI of 40, the BP limb length will be 150 centimeter plus 40, that is 190 centimeters. Above the age of 55 years, we further reduce the length of a standard bypass length to 130 centimeters. That is, patient of 56 years of age and 40 BMI, the BP limb length will be 130 centimeters plus 40, that is 170 centimeters. So this is the formula we have made, and according to this formula, we have a good excessive weight loss. We do not have much nutritional deficiencies, macro as well as micro, and longer bypass lengths. Sometimes we have to be done, and I feel it should be done by an experienced MGB surgeon, where you know that patient will be able to stand a longer bypass length, and patient has some reserve to stand that bypass, and patient should be very compliant, educated, listen to your advice, listen to your nutritionist advice, and maximum value of BMI we have taken is 60. So if a patient is of 70 BMI, we will still calculate as 60. If patient is 80 BMI, we will still calculate as BMI. 60 BMI. So beyond that, we do not calculate. So this is the formula what we do. And as you can see, the average of this comes to around about 175 or 180 centimeters of the BP limb length in all my patients. So this is what we do in all my patients. And by doing this, we are able to reduce macro as well as micronutritional deficiencies in my patients.
Sir, excellent. Sir, regarding this redo surgery, same formula. A patient with weight.
No. This is not for redo surgeries. For redo surgeries, this by BP limb length will not work. The patient will not have good weight loss. In those patients, we always have a longer bypass length. So nothing less than 200 centimeters, sometimes even 250 centimeters we have done in super obese patients. So smaller bypass lengths really don't work. And not only the BP limb lengths, you also have to revise the pouch size as well.
Sir, regarding this redo surgery, are you prefer to measure all, whole the bowel length?
Yes, well, all whole length is measured because at least you have to leave about 3 meters of intestine, distal intestine, because if you don't want that nutritional deficiencies or problems like dumping or diarrhea in your patients. So we always make sure that we measure whole of the length, because in sometimes we have seen that the the small intestine size is about 6 meters only. So you cannot do a longer bypass. So we have made it a routine and the protocol in my practice that we do measure whole of the small intestine.
Sir, are you prefer MGB only for metabolic issues, like for the treatment of diabetes with low BMI? Just imagine a patient with the BMI 27. Patient is 60 years old with history of 30 years of diabetes, but C-peptide is still 2 plus. But patient is not receiving insulin. In such a case, Patient is also hypertensive, male patient. So are you prefer MGB, and with which, if you prefer, what will be BP limb?
At 60 years of age, I will not prefer doing mini gastric bypass at BM of less than 30. Because you are not, maybe you are able to get hold of the diabetes problem, but you might land your patient in other problems like micro or macronutrient deficiencies. So I will not attempt it. Yes, if patient is comparatively young or who can withstand this surgery, and for metabolic achievements, still nothing less than 130 or 150 centimeter of BP length bypass, nothing less than this is going to work for the metabolic resolution of diabetes or other problems. So sometimes 60 years, patient might go into some nutritional deficiencies. I will not advise, I will not attempt at this age. In the younger age group, yes, 30s or early 40s, I can still think of the, not at 60 years of age.
So if patient is younger, so just I change the question, but BMI is 27, diabetes, so type 2 patient is 45, 50, but healthy patient. So you see, yes, patient is okay, there is no issue. Have you any experience for such a case?
Yes, yes. In those cases, in younger patients, I have attempted in few patients, about 14 or 15 patients, and they lost about 14 or 15 kilos of weight only, and the diabetes really, they had some resolution in type 2 diabetes. Their oral hypoglycemics, or even if they were on insulin, that dose was considerably reduced, and they could withstand the procedure very well. Yes, in younger patients, yes, we can attempt that.
And BP limb was 150 in such a case.
Yes, 150.
And also that gastric pouch was same like you do in morbid obese, or no, that was a little dilated pouch.
Yes, gastric pouch was little bigger in size. Yes, you are very much right. We don't make very tight pouch in those patients. We make so that we don't, the purpose is not to lose much of the weight, but we want some metabolic resolution, and that can be achieved with a bypass.
Okay, sir, excellent, sir. Sir, regarding, so again, the same, have you any other slide or video you want to show us?
Yes, there's one video I wanted to show you.
Please, sir.
So, is it, yes, can you see that?
Yeah, sir, we can see. Please click.
So this is a short video I've made, about 8 to 9 minutes. So how I do mini gastric bypass. This is the insufflation.
Sir, no, click the video. Still we cannot see the video. I cannot see the video. So you must click that one. So yes, I can see your desktop, but cannot see the video.
Just give me a minute. Is it visible?
No, no, sir, not yet.
Now?
Sir, not yet. We cannot see the video. Yes, something.
Let me.
No, yeah. Again, you can try now. Again, you can try. Maybe you can. So share slide. Just share a screen, and then you will go to desktop. Now you can click your video. Yes, yes. Click this one.
Now?
Sir, still we cannot see, unfortunately.
I think we can wait for a few seconds. Sometimes it takes time to.
Fine. Okay, okay, sir.
If it starts, let me know. Otherwise, I will stop this.
Yeah, I will just, yes, sir. So we can wait, no issue. But sometime it will come earlier, so it will take time. There is no issue because this KB, so kilobyte is, I think, more. So, sir, just now we can talk about the position of patient. So your position is French position?
Yes, the cameraman will stand in between the legs. I stand on the right side of the patient. Still, it is not visible.
No, sir, I cannot see.
Okay, then we can straightforward discuss this thing.
We like to see your, if it is possible, it will be good. Because if not, okay. Okay, sir, just you can explain your technique. If we can share again, no issue. You can try again. So just you can click share a screen and you will go to your desktop. And hopefully now it will be, yes, you double click here, double click. You can do double click.
Yes, it is showing on my laptop actually.
So, but I cannot
Okay.
see. So maybe there is some issue.
Some format is different. I don't know what is. So back to what you said. Anyways, we can discuss otherwise.
Yes, sir.
So,
Please.
technically, the steps are that I stand on the right side of the patient. My camera assistant will stand in between the legs. My first assistant will stand on the left side of the patient. Patient is in the head up position, about 45 degrees, and there's no tilt either right or left. So I use a 5-port method. So camera is always supraumbilical. So there are two 12 mm ports which are on the right side. One is on the right hypochondrium and another is at fingers breadth below that. Similarly, two 5 mm ports on the left side. One is on the left hypochondrium and another one is at fingers breadth below that. So I start dissecting from the lesser sac, create a space just for my staple to go inside. My first staple is always almost from the epigastric port, and that will always go perpendicular to the lesser curvature of the stomach. And this is always 45 green, so of echelon ethicon. And I fire about 35 mm fire. And the second one is also from the epigastric port, and it is at right angles to the first fire. So that means in the axis of the stomach going longitudinal upwards. So these are first two green fires. The rest of all the fires are done from the right side only, but from the lower port, not from the epigastric port. So all the fires subsequent are either blue or white by ethicon, and takes about, I think, 5 to 6 all the fires till the angle of his we separate. That is about 18 to 20 centimeters the length of the stomach pouch. The second step is to find the ligament of trites and calculate the BP limb length. Suppose the BP limb length is 150 centimeters. So we measure that part. And another important thing is where to make the gastrotomy. This is very important. And this also technically have changed over the years. Initially, we used to do posterior gastrotomy, then we started doing anterior gastrotomy, then we started doing it in between that two in the middle of the first fire, then towards the left of the first fire, then towards the right of first fire. So we have done in all the places. So now what we have seen that your gastrotomy should always be on the right side and more towards the right side. And you should always divide the first fire. Why on the right side? Because we don't want our anastomosis to have a compromised blood supply. So because we have separated some vessels on the lesser sac and on the right side, still there's more blood supply as compared to the left side all, because left side stomach is all bare, there is no blood supply. We have separated it from the residual stomach. So I try to do a gastrotomy more on the right side, and then the gastrojejunostomy is done. It is done by 45 mm fire, and it is always 45 mm wide. We do the closure of this gastrostomy and the enterostomy with a 30 V log, which is a barbed suture, and we do in single layer in the running manner. This is how we perform gastrojejunostomy. And in all my cases, you do the methylene blue test to see for any leakage as a routine. And another thing which I have added in my practice now is that sometimes we were finding that after doing everything, after achieving hemostasis and checking all the staple lines, still post-operatively, patient used to bleed sometimes intraoperatively or sometimes in the intraluminal. In few cases, we have found that there was loss of blood and patient had become pale and tachycardia and pain sort of thing and low blood pressure levels. So now what we do, where after achieving all the hemostasis, after doing all the methylene blue test, we desufflate the patient. That means we take all the CO2 out, make the patient straightened, and we relax the patient. Patient is still under anesthesia. After 5 to 10 minutes, we waiting, because during insufflation, what happens because of CO2 pressure, sometimes the small oozers will not ooze because of the pressure of the gas inside. And once you desufflate, the vitals of the patient come to normal level. If there is some oozing, and when you re-insufflate the patient, when you put the CO2 again inside, you can see some oozers, and you can always go and click them, put a clip on that, or you can do some suturing on that. So that is very much possible. And if you see something very blackish or reddish inside your jejunum, some clots are there, you can always do endoscopic there and then on the table. And the intraluminal part is also you are able to manage that. So this is one new thing we have added in the last 2 or 3 years. And with this practice, we are able to reduce at least the extraluminal part of the bleeding. We are able to take care of that. Hardly we have seen in subsequent that you have some staple and bleed, or there's fall in hemoglobin level after surgery. This is another thing what we have added. Normally, the patient for the surgery takes about 30 to 45 to 60 minutes, any mini gastric bypass with all my proper assisting team. And the other protocol is that patients are kept in the recovery room till patients are able to walk itself, and then the patient shifted to their room. That means patients are kept in the recovery room for about 6 to 12 hours. Patients, when they start walking, or then when they start sipping liquids, then we shift the patients to their other rooms, and they can be where they can stay.
Sir, excellent demonstration. So my concern may be, so this is my personal concern regarding this gastrojejunostomy. When we will be more medial to this gastric pouch, as you have mentioned, so there is a lot of fat tissue, and also when we do there this gastrojejunostomy at the posterior side, there is more chance of twist of this gastrojejunostomy. So I am right, or what is your opinion about this?
Yes, Dr. Iman, you are right. To tell you one interesting case where we had done some gastrojejunostomy on the posterior side, and what we found when we did the dye test, when we were putting dye under pressure by clamping the two limbs of the jejunum, my tube was rotating. It was twisting, what we found, and normally it would not do. So, but we took the chance. We did not do anything because the anastomosis were patent. But that was I say, bad for us and for the patients. The very second day, when patient was started on oral liquid diet, patient started vomiting because of that twist. Whenever the patient was taking, it was twisting, and patient started vomiting. We waited for a second day, maybe with antiemetics. We thought patient will settle down, but it did not settle down. So that is one very important message. On dye test, you do not see only the leakage, but you also see the contour of your uh, gastric pouch. If it is very much rotating, you have to fix there and then only. So in that particular patient, I had to redo my gastrojejunostomy. Rather, I would say I converted that patient to Roux and Y gastric bypass, because I did not want to take another chance. My tube was rotating. The distal tube was rotating when we were doing the methylene blue dye test. So that is one important thing I've learned, that your tube should not be rotating when you do the methylene blue dye test, because if it is rotating, you fix it there and then, otherwise you are going to face problem with that patient.
Sir, regarding, so earlier, because at your earlier demonstration you have mentioned, so because now you have experience of more than 1 decade of MGB, but at earlier stage, and also I am your follower of your papers, especially your paper, yes, and that was great research work from your side, and also, in my opinion, great contribution for our obesity society. So what is my question? So regarding, so in those cases that you have faced severe malnutrition, so what you did in these cases? Have you revised these cases, all of these cases, or so shorten the BP limb? What was your protocol in those cases?
Very interesting, Dr. Abbas. I have done everything for my malnutrition patient, for the, especially the macronutrition deficiencies. I have done everything for them. As we discussed in the beginning, out of my series of about more than 400 cases, the initial series, which we published in 2015, now we have changed some practice, like we have applied some formulations now. We hardly encounter these problems anymore. But in my initial series, we had a severe nutritional deficiency patient. About more than 20 patients out of 400 patients, we landed up with severe hypoalbuminemia. We were not able to correct that with best of the nutritional support. So patient was given sometimes parenteral nutrition or the other things. Out of 3 particular patients who were rapidly deteriorating, they became so weak in those patients. In one of the patients, we reduced the length of the bypass. Out of 250 centimeters, I reduced to about 100 centimeters. That was one particular case. What happened that with that case, I'll tell you. In 2 cases, I simply undid the mini gastric bypass. That means we took a gastrojejunal was divided. Again, jejunal anastomosis were maintained, and gastric anastomosis was done. There is complete reversal was done in 2 cases. Subsequently, in these passing years, we have been referred cases of mini gastric bypass, of severe nutritional deficiencies. We have reversed the cases done by at other centers, apart from my own 3 cases. So I have a data about more than 30 cases we have revised or we have reversed mini gastric bypass. So what is the difference between a reversal and what is the difference of revision? That means shortening the length of bypass. In the reversal, yes, you get very fast results and you are able to help your patients a lot, because very easily you can correct that problem of hypoalbuminemia very soon. But when you have shortened the length of bypass, this problem doesn't solve very fast. It will take another few weeks or few months before the patient settles down. So I will want to give this message that if you have patients of severe albumin deficiencies, which is not responding to dietary modifications, I would say that you just undo your procedure. Don't land up the patient again by shortening the length of bypass, because these patients are in life-threatening situations now. If you want to save them, just reverse them, because if you, by shortening the bypass, of course you are decreasing the this malabsorption thing, but that might take longer time. You want duodenum inside, you want duodenum to start doing action. So for duodenum to start playing again, you have to simply undo the procedures. Otherwise, I have not done, recommended is that you do a feeding gastrostomy in the bypass stomach, or a feeding gastrostomy sort of thing. But life-saving in my practice, I have just reversed the bypass and I've been able to help my patients.
Excellent, sir. Thank you, sir, really. And it is a great information. Sir, have you faced some time, you will see, yes, you did surgery for your patient. That was standard MGB, standard. Yes, your BP limb, everything standard. But patient stopped to lose weight. So that routinely I also face in UAE, in Dubai. So what you did in such a case? So yes, standard MGBs, everything standard, but now stopped.
Sometimes you are just helpless. Sometimes the weight is so less that with the same bypass length, another patient will lose so many kilos, and some patients would hardly lose. In those patients, if you are very much sure about your procedure, that you have done fairly justice to your surgical technique, there's no flaw in that. Me and my nutritionist we would simply guide the patients to go and change their dietary habit or sort of things and add lifestyle changes to that rather than revising the surgeries or increasing the length of bypass. Because by doing the standard MGB, if there's hardly any weight loss, but increasing the limb length, I don't think so you'll be able to do justice to your patient again. So I think lifestyle changes is the recommended thing, and sometimes everything is not in our hands. You know that.
Sir, are you also suggest medication like Saxenda, Trulicity, or something like this, that analog of GLP-1? Have you any experience in such a cases?
I don't have with these things because these are not available in India. Yes, with the liraglutide, we have tried in few patients, but with mixed results, not very promising results. With mixed results, there again the weight loss of a few kgs only, 4 or 5 or 6 kgs, and that is not very sufficient. Again, everything comes with a cost. These are not very cheap medicines. They are expensive medicines. As long as you are using that, your patient is going to lose few kilos of weight loss. But if you want your patient to lose it about 30 kilos or 40 kilos, I think these things are hardly useful, liraglutide.
Sir, excellent. Sir, so regarding, I have another question, because also I have some questions from Facebook viewers, but most of them so already so answered in your discussion. That was excellent. So, sir, regarding dumping, have you faced dumping in your patients? And what
Yes,
you did?
of course.
Yeah.
Yes, we have faced dumping, and I think the reason of dumping in mini gastric bypass are mainly two reasons. One is in response to the dietary thing, that is simple carbs, especially the sugary things when the patient takes, and usually there is a phenomena called hyperinsulinemic hypoglycemia. So that is one reason. So that can be corrected with, I think, dietary modifications. The second reason can be your undigested food when it hits the distal part of the intestine, and there is a reaction of the distal intestine, then you can have a dumping. So in both the cases, I think dietary modifications will help the patients. More of protein, less of simple carbohydrates, or the way, the habit, the way one patient choose food and how slowly they take and the right type of food. So this is the probably management. Yes, in severe cases where nothing is helping the patient, again, you have to, I think, undo your surgeries. I have not done, but I've seen people doing when the dumping is not responding to any dietary or lifestyle modifications, then that is a thing. Most of the patients, if you guide the patient, especially dumping occurs when you increase the BP limb length, that the chances of dumping will be more, either in the form of diarrhea or hyperinsulinemic hypoglycemia.
Sir, thank you. Sir, have you faced any weight regain after MGB? Now, more than 1 decade you are doing MGB.
Dr. Bas, to tell you the truth, in all bariatric surgeries, there's a little bit of weight regain. No surgery is foolproof. But if you compare the results of mini gastric bypass with other surgical techniques, Roux-en-Y sleeve, the weight regain is far, far less as compared to other techniques. But again, if patient is very compliant and self-motivated, and you tell them that you can prevent weight regain, and if they want, they can prevent that. But if you say that you have done a foolproof surgery, that surgery is still to come.
Sir, what is your post-op dietary protocol after MGB?
Uh, apart from this, that good protein and less of simple carbohydrates, more complex carbohydrates and less of fats, what protocol we follow in my practice is that the day of surgery, we put the patient after 6 to 7 hours when the patient is fully conscious, we push the patient on oral liquid diet the day of surgery itself. First post-operative day, the patient will have some liquid diet only. Second post-operative patient, we put the patient on second. Patient is mostly discharged when they go home. Thick liquids are allowed to the patient for a few days, and a semi-solid diet is started on the 4th or 5th day. The solid diet, that means the chapatis or the rice, which is a traditional Indian food. We normally start all the after removing the sutures. That was the 8th or 10th day of surgery, when you see the patient is not having any problems of by eating this soft diet. We normally put the patient on that. Dietary values, they are calculated by the team of nutritionists. They, according to the eating habits of patients, whether patient is vegetarian or non-vegetarian, what kind of food they want, what is their age group. So that is all managed by the dietitian.
Sir, excellent. What is about supplements? So, are you used until which time you suggest your patient?
Yes, supplements like multivitamins, calciums, are we prescribe in all our patients. We tell them to take lifelong. Iron supplements, yes, we tell them to, for especially young menstruating women, we tell them to take, because one frequent problem we see in this malabsorptive procedure is iron deficiency anemia, especially in young females. So it is commonly found, and we tell them that they have to take iron. If I exaggerate on that, sometimes you have to replace iron in intravenous also in few of the patients when the oral is not able to help. We have to give them IV replacements as well. So multivitamins for lifelong. Sometimes calcium is also recommended lifelong, and that's it mainly. And
Sir,
vitamin D, yes, vitamin D is one thing deficient. So we have to frequently check the patients. If the patient is following us, then it's okay. If the patient is from outside country, then we tell them the battery of tests to be done annually or after 6 months, according to the nature of surgery. They should get it done. And these are a common thing: iron, vitamin D, multivitamins, B complex, B12, calcium. These are the routine things we tell our patients. And sometimes even protein supplements are recommended. If the patient is not taking enough of other protein supplements in the form of isolates or whey is also recommended to the patient.
sir, one of the main issue, especially in female patients, is hair fall after surgery. Have you any protocol? What you do?
Yes, hair fall, you cannot, it is bound to occur because you are producing some man-made malabsorption. And yes, hair fall does occur, but it is always hair fall. It is not a hair loss, what I have seen.
Yeah.
So when that golden period of weight loss stops, I've seen the hair coming back. And to see that it doesn't occur in every patient. So in some of the patients, hair fall is very, very less. In sometimes it's much more. So again, multivitamin, the role of zinc, vitamins, proteins, biotin, this is a routine to be followed. And most of the times, like even younger unmarried girls or boys, they also undergo surgery where beauties are one of the cosmetic things when made a concern. I've never seen any major problem out of that. Yes, but we consult the patient before the surgery that there's such a such thing as going may occur, and you have to take all these supplements for that. You have to take a good protein diet for that. And usually these things are manageable. After about 18 months, I've seen that hair fall usually 18 months to 2 years, it usually stops. And then this fall thing, they start coming back. Then patients are again happy again.
Sir, excellent, really, and really thanks for sharing your experience. So, any message, sir, for youngsters? So, who are just going to start MGB?
Yes, they must start MGP if they have some interest in bariatric surgery. But I'll tell that don't do or learn only MGP. They should also learn other procedures, because you have to know what is sleeve, you have to know what is do and why, basic procedures. Sometimes you need some exit strategies, some complications can occur, so you have to manage those patients by converting to other procedures, be may do and why or sleeve or sometime. So you have to learn all the procedures. Don't think that you will learn only MGB and you'll be safe. You have to learn all the procedures, educate yourself, go to your seniors, attend the conferences, workshops. There will be so many doubts when once you start doing it. So for your first few cases, don't attempt to do it alone. Do it under your guidance of your seniors or the expert surgeon. And MGB is one thing which is going to stay. We have more than 2 decades of mini gastric bypass results now. because Rutledge started doing in the year 1997. So we have results of more than 2 decades now, and it is a really good procedure. So this is a procedure which is going to stay forever, I think so.
Sir, really, so much thanks for your time, for your support. And again, we need your support because we will continue our series of then a sleeve gastrectomy, then Roux-en-Y, then redo surgeries, and definite in our coming series. Again, we need your support and special thanks, sir, for your time.
I'm honored, Dr. Imran Abbas. I'm honored so much. Thank you so much for taking me on your webinar.
Also, so much thanks, my viewers, and that follow at this late time in Asia and also from Europe and different parts of the world. And special thanks. And we will continue our series. And next week, we will have another legend from Egypt, Professor Ala Abbas. He is also well known professor of surgery and also well known bariatric surgeon and expert of MGB, OAGB. Hope next week also our interview will be very fruitful. We will continue our series till June. And so we will end this series with Professor Carbajo, who is pioneer of OAGB. And then at 13th June, we will have sum up session. So my request, please continue your support, especially my viewers. If you have any question, yeah, you can ask question also in your comments and also during live stream. Sir, so much thanks again. I know now the midnight, and also my best wishes for all of your nation, especially in this COVID-19, and stay blessed, sir.
Thank you so much again. Thank you so
Thank
much.
you, sir. So much thanks, sir.